Hello, everybody. Thank you so much for coming. If you could just put a yes or a thumbs up in the chat if you can see us or see the slides as well, that would be perfect. Make sure that we're actually broadcasting out to you. Yeah, brilliant. Thank you so much. So we've got another really interesting session today looking at reproduction and fertility. As ever, we'll just wait a little bit late and take the opportunity to tell you about next week's session before we get on with this one. So next week, we're looking at dermatology that's relevant to queer population. One of my friends, an F1 working in Cornwall, Olivia, is going to be doing that one. So I'm going to put the link in the chat, and it's just a normal registration form. It will be same time, same place next week. So yeah, that one's in there. At the end of the session, we'll put up I'll put a link in the chat of the feedback form, and there'll be a QR code on the PowerPoint. If you could fill that one in, that'd be really, really helpful. And then once you fill it in, you'll get a certificate of attendance as well. So we can help each other out. And again, as always, any questions as we go, pop them in the chat and we can look at them at the end, or Emily can deal with them at the time. Yeah, because a couple more minutes for some more people to join, and then we'll get going. Okay, let's get started then. So I'll hand over to you, Emily, let you introduce yourself and tell us about reproduction and fertility. Thank you.
Brilliant. Thanks, Alec. Yeah, so I'm Emily. I'm a final year medical student. And yeah, I kind of got involved with this through, I did some teaching last year at medical school about queer health. So yeah, that's how I got involved with this. So yeah, today we'll be talking about reproduction and fertility for the queer community. I've tried to make the slides look vaguely nice, but forgive me if the design is not that nice. Okay, so this is what we'll be running through today. Yeah, as Alex said, if there's any questions at any point, just feel free to pop them in the chat. If I don't see them, I'll come to them at the end. So yeah, I'll just do a brief introduction to the topic, and then we'll go over fertility issues, and then some stuff about assisted reproduction, and then we'll kind of summarize everything we've talked about. Okay, cool. So preserving fertility and assisted reproduction is a rapidly developing area of medicine in general. And today we're going to talk about how this impacts queer patients and if the progress in the field is truly equitable between queer patients and non-queer patients. So we won't be discussing fertility or assisted reproduction for intersex people because this massively varies for different individuals, but it's also important to be aware of that and aware that there'll be lots of kind of variation for different people. Fine. So yeah, we'll talk about fertility and preserving fertility first. So I'll be talking mostly about kind of transgender women and transgender men while I'm talking about this, but obviously all of the things that I'm talking about apply to non-binary people and anyone in the kind of spectrum in between. Yeah, cool. So fertility preservation for transgender men and non-binary people. So this is advised to happen before someone starts on T. So it's kind of thought that this will, number one, usually help with the success of the fertility preservation, and it will also avoid the dysphoria that someone might get if they stop T after they've already started it. But you can also do this 3 months after cessation of T. So if someone doesn't think about it or isn't aware of it before they go on T, then they can stop T to have fertility preservation treatment. So what happens before is you'll get a consultation. It will talk about what procedure you're going to have. There's a few different procedures that we'll talk about on the next slide as to how your fertility might be preserved. And then you'll get some ultrasound scans. You'll do a blood test, which will include things like HIV and hepatitis, because at the moment, storage banks can't store gametes or anything like that if you are HIV or hepatitis positive. So that's something that is important to mention to patients if they're considering this. And then you have to do a consent form for your tissue or gametes to be stored, and that will specify the length of time that it needs to be stored for. And the important thing about this is that the consent only lasts for whatever length of time, so like 10 years. So patients need to be aware that they will have to renew their consent every 10 years, so to keep up to date contact information with whoever's storing their tissue. And obviously a massive thing with this is that the funding has a massive variety across the country because it's determined by individual care boards. So it will vary a lot, and the funding is for storage for a very specific period of time, and if it goes beyond that period of time, then the patient will have to pay out of pocket, and there's no additional funding on top of that for assisted reproduction or conception. So the two types of fertility preservation, the main two types are gamete cryopreservation, which is the most common one, and then a kind of new, slightly more experimental one, which is gonadal tissue cryopreservation. So with gamete cryopreservation or egg collection, it's usually 10 to 14 days of FSH injections and then gamete retrieval under deep sedation. So that is usually done vaginally, but depending on what patients prefer and patients' comfort levels with this, it can also be done via the abdomen. So that's something that you might want to talk about with the patient. In general, the survival and success of gametes is pretty good. But it is individual, so that it'll be more successful if the patient is younger. basically. In terms of the potential side effects, you might want to warn patients about. It's kind of the typical side effects for similar to IVF, egg retrieval. So estrogen can, you'll be giving, as you're stimulating, the estrogen will be produced, and so this can affect your mood, can cause bloating, and obviously also may cause some, and it may also cause some engorgement or tenderness in people's chests. So obviously that can be a source of dysphoria for people. So just important things to warn them about before they go through with the cryopreservation. And main thing you need to warn them about is ovarian hyperstimulation syndrome, which you may have heard about before in the context of IVF. So it's like extreme bloating and abdominal pain, and patients will need to go to hospital immediately if they experience that kind of symptoms during their treatment. Fine. And then the other type of preservation is gonadal tissue cryopreservation. So this is removal of gonad tissue under general anaesthetic. There's currently no funding on the NHS for this, and it's not well established in transgender patients. So it's previously usually been used for like young cancer patients who may want to preserve their fertility while they're going through chemotherapy or something. So it's it's quite experimental in transgender people, and is so only privately funded at the moment. And then moving on from the kind of fertility preservation side of things onto contraception. So obviously transgender men are still fertile, and that's something that's really important to think about and make them aware of, that testosterone or GnRH analogues, whatever HRT they're on, are not forms of contraception and will not stop them from becoming pregnant. And that's a really important thing to communicate to people, because there's a kind of an assumption that would act as contraception, but it doesn't. So another important reason is that testosterone is teratogenic. So obviously, if someone did end up becoming pregnant whilst on testosterone, that's also an issue as well for the fetus. So when you're asking about whether people need contraception, you want to be asking open questions about what their need is, whether they need contraception or not. So ask clear but sensitive questions, and clearly communicate what you mean. But try to avoid any stigmatizing language or assuming any kind of ways that they would refer to themselves, and only ask questions if relevant. So the types of questions you might want to ask are things like, are you having sex? Be clear about what types of sex they're having. It may be uncomfortable for some people to refer to sex, like penetrative sex, as vaginal sex, so you can just describe it as penetrative sex and ask very specifically if there's any chance they could be pregnant. And that kind of question usually establishes that pretty easily. So, and then in terms of which contraceptions they can then choose if they do need to be on contraception. So there's kind of the regular day-to-day contraception options. So you want to avoid any like estrogen containing contraceptives. So for example, the combined pill, because obviously it contains estrogen, and this will disrupt, if they're on testosterone, this will disrupt the effects of their testosterone. So you want to avoid any of those. You can go for hormone-free options, so barrier contraceptive or the copper coil, or you can go for progesterone only options, and those have been shown not to affect the effects of testosterone, so it doesn't interfere with people's T. So you can use any of the progesterone-only options. And in terms of emergency contraception, if someone has had unprotected sex and is worried that they might get pregnant, testosterone is not thought to affect the efficacy of any of them. So all of the different types of emergency contraception you would usually use in cis women are safe in trans men. Yeah, you can use any of those depending on what the patient prefers or where in their cycle they are, etc. Okay, any kind of questions or comments on that section at all? Please pop them in the chat. Yeah, I'll carry on and I'll just check the chat as we're going. So yeah, so we talked a bit about fertility preservation and contraception, and I'm going to talk a bit about pregnancy now. So trans men and non-binary people can get pregnant. So obviously, as we talked about, T is not a contraceptive, and it does not, well, it can affect fertility, but not necessarily. So in kind of the research generally, there's a similar chance of pregnancy to cis women once testosterone is stopped, if there's no other fertility, underlying fertility problems there. So yeah, in terms of when you're talking to someone about their pregnancy, you want to use whatever terminology they prefer. So don't assume what they would prefer. Often terms are used such as a lot of trans men who get pregnant and then go on to feed their babies describe it as chest feeding rather than breastfeeding, and don't assume their terminology for genitalia. You can ask questions about that if that's relevant. Again, don't ask if it's not relevant. But if you're kind of, for example, if you're the midwife looking after them, and you want to know what his pronouns are, what his terms are for his genitalia, then you want to ask that so you can be clear to communicate if you need to during birth. Yes, again, testosterone is teratogenic, so you'll have to advise them to stop that during pregnancy. And some things to you can tell patients about stopping testosterone, because obviously, understandably, that can cause quite a lot of, the thought of that can cause quite a lot of anxiety for trans men. So kind of reassurance you can give them, reassurance and warnings you can give them. So their periods can restart, and obviously they may get body shape changes. So for example, their hips shape might change, and obviously there's an increased risk of mental health issues, not only because that's increased anyway in pregnancy, but because of the dysphoria that can come with getting pregnant for trans men. But they shouldn't have any changes to their voice. They shouldn't have any changes to their facial hair. Those are some things that should stay the same for them. And obviously they still will need to talk to their prescribing doctor, whoever that is prescribing them tea, to talk about stopping it. Yes. So kind of the issues around pregnancy. So obviously there's a big issue with gender dysphoria. It's kind of, it comes with the pregnancy is obviously a very it's a very gendered thing. And so both stopping testosterone can cause the gender dysphoria as well as pregnancy itself. There is also a lot of misgendering or misunderstandings that can happen around pregnancy. So obviously it involves a lot of visit O&G and a lot of visits to clinics which are often set up for cis women, and so are very gendered, and it's quite common for trans men to get misgendered in those kind of situations. So obviously there's anxiety around that quite often. Also, it's important to ask if you are kind of working in O&G, kind of if they have any anxiety around gynecological examinations, which is also quite common, and just being sensitive around that, and again asking about what they would prefer, things like that, to try and make people more comfortable. In terms of support that they can access, obviously there's kind of basic support in terms of who to refer to from the GP, and then Trans Fertility is a big charity that helps because they've got a lot of contacts of people who've been through this before, so other trans men who've been pregnant and can share their experiences. And then obviously if there's any issues with their care, if they're feeling uncomfortable, then PALS in a new hospital would be a good place to point them to if they need to like change midwives, if they're, for example, not comfortable or something like that. And then in terms of childbirth, when it comes to that point, the most important thing is just discuss all of the options, and again, be really clear with what each will involve and what the patient wants. Yeah. Cool. So yeah, as with pregnancy, trans men also are able to chest feed. So this is something that is good to discuss with someone before the birth, in terms of whether they what they want to do about feeding the baby and what their preferences are. So in terms of chest feeding, so that's feeding your baby with milk from your chest. So after top surgery, it may still be possible, but it isn't always possible, and it's important to manage expectations of patients around this, because it's not possible to know how much milk will be produced. The babies may need supplementary feeds, they might have difficulty latching, all that kind of thing. So it's important to tell that to patients. Testosterone can also decrease milk supply because it interferes with prolactin production. So it can cause a decrease in milk supply, for which reason is often recommended if someone wants to chest feed, that they stay off tea for a short while postpartum, so that if they want to chest feed, the milk supply is hopefully increased. But obviously that's up to individuals, and you can still chest feed if you're on testosterone. It's also really important to mention that if someone's binding whilst chest feeding, there's a much higher chance of mastitis. So you kind of tell them the red flags, getting swollen, hot, painful chest. And the kind of advice you can give people around this is to wear, for example, to wear a larger size of binder, just one or two sizes up from whatever they would normally wear, and speak to their midwife if they are worried about having mastitis. In terms of other feeding kind of options, there's kind of skin to skin and at chest supplementers. So obviously for a lot of people and for babies, skin to skin is important for bonding. So a lot of people will still want to nurse their babies, even if they're not chest feeding them. So there's a lot of at-chest supplementers, which are basically ways you can feed your baby using formula while still having them on your chest, and having that skin-to-skin contact. Yeah, so that's an option for people. In terms of kind of the more dysphoric side of the fact that obviously after pregnancy, your body will produce milk, and that can obviously be a very dysphoric thing for trans men. So that we can offer lactation suppression medication, so cabergoline. So that's something you can offer people if they don't want to chest feed, they don't want to have that, and actually it's making them very dysphoric that they're starting to lactate. So that's a way you can support people. And if they aren't interested in, they don't want to chest feed, but they still want to for their babies to have human milk, for whatever reason, be that like antibodies, whatever the reason is for that, the benefits of it. You can apply to human milk banks for support. So these, you might have heard of this before in the context of like premature infants, like getting human milk for them. And obviously that supply for premature infants is prioritized, but you can apply for other reasons. So it's worth discussing applying to those with patients. So that's kind of, it's a very whistle-stop tour, this, but that's kind of the fertility side for transgender men and non-binary people. So we're going to move on to transgender women and non-binary people. So we'll go through it in the same way. So we'll talk about their fertility. So again, there's a similar kind of initial process. It's the same kind of thing of cryopreservation. So there's a similar initial process in terms of the consultation and everything like that. You're advised to stop estrogen or anti-androgens, whatever you're on, for 3 to 6 months before going through fertility preservation. And again, it's ideally advised that you would do it before you go on any estrogen or anti-androgens. So they need to stop estrogen because around 7 out of 10 people who take estrogen stop making reproductive cells. So the time allows for the reversal for this. But you do need to warn patients that they may be subfertile after they've started estrogen. So yeah, it's really important to try and make patients aware that the best time to do this is before they start estrogen. Obviously, that's not always a viable option, but yeah. And then in terms of gamete freezing, again, it's getting a sample. So this can be done either by masturbation, which you need to clarify with the patient so they know and they're comfortable with that, or it can also be done during orchidectomy or genital reconstruction surgery. But that needs to be clarified and discussed with their surgeon, and you need to get permission for the storage at the time of the surgery. But that is an option. So if someone wants to have some kind of surgery, then that's the thing to discuss before that happens, whether they want to have fertility preservation during that surgery. And then they'll analyze the quality, store those gametes, and then tissue freezing. Again, this is experimental, not really got any funding on the NHS, and it's usually only done prior to puberty. So it's not very common at all. It's only done through private. And then in terms of contraception, there's obviously much less options than for transgender men. So it's barrier contraception, or there's surgical procedures. And obviously, as with all surgery, then you need to discuss the risks. You can have a vasectomy, which is obviously reversible, but not guaranteed to be reversible, or an orchidectomy, which obviously is permanent. And then in terms of pregnancy, it is now possible for uterus transplantation to take place. So this is again something that hasn't happened. This is a kind of theoretical thing that could maybe happen in the future, but this is not a thing yet. So in the future, potentially, we could do uterus transplantation. So at the moment, it's been done in cis women. So there's been 70 procedures with 23 babies born, but it's not yet been performed in trans women, as I said. It's a very complex surgery, and the kind of thinking about it is that it will be more complex in trans women due to differences in kind of pelvic anatomy in terms of the vascular structure. So that's why it's partially why it hasn't been done yet, but there are people looking into doing it. So what will happen is the surgery will be carried out, and the uterus will be transplanted. Then you have to wait 6 months until you can then get pregnant, carry the pregnancy, and then the uterus will be removed from the body again after the pregnancy. So obviously there's a lot of risks associated with that. So the bleeding, infection, nerve injury, all the standard ones associated with surgery, and then obviously the risk of organ rejection with it being someone else's uterus. So you have to take immunosuppression to prevent the rejection. However, you only have to take it for the length of time you have the uterus, which would be about 1.5 years for you to carry the pregnancy. So it is kind of possible. And obviously, you'd have to have IVF. It's the only way so far of getting pregnant with a transplanted uterus. So this is not something that happens at the moment, but an interesting thing that maybe could make stuff a bit more equitable in the future. So in terms of feeding, transgender women can feed their children, even without the whole uterus transplantation thing. There's a thing called milk supply stimulation, which you might have heard about potentially before. And there's been multiple successful cases reported of transgender women being able to produce milk. There's this certain, and the kind of, it's all been induced lactation, and then it's been maintained, and the nutrient analysis of the milk and everything suggests it's good for the babies, and there's been basically no issues with any of the cases that's happened. So it is a really good option for people if they want that. So there's a kind of protocol that happens to help someone produce milk. So it's quite a complicated protocol, but basically it's a combination of taking various drugs. So you take the combined oral contraceptive, you take domperidone, and then you take, and then you will start to pump milk once it gets close to the time where you want to start feeding the baby. So it's been done in cis women before for quite a while, and obviously has only more recently been started in trans women. But So further research is needed to like optimize it and make it best for trans women, but it does work. And there may not be a massive amount of milk produced. It varies a lot person to person. So there may be a need for milk supplements and things like that. So that's always something to warn people about. And obviously you can still have the same issues with feeding, so latching and stuff like this. And then obviously another option, as before, is skin-to-skin and at-chest supplementers if you want to nurse the child again. And so you can see this kind of diagram. It's kind of all of this is nursing the child, so that all has the same kind of effect. And so, yeah, it's important to discuss with patients that their expectations and that the main thing is nursing the child, regardless of what happens. Okay, so that's the fertility section. I hope it made sense. It's quite a lot to go through, but yes, pop any questions in the chat. So we'll move on to a bit about assisted reproduction. So there's several different ways that couples can conceive in queer relationships. So the first way is donor insemination. So this is commonly used, for example, by lesbian couples, or I just realized I've been clicking the slides on the wrong thing. Okay, there we go. For example, but yes, so there are two different options. So there's intracervical insemination or intrauterine insemination. The ICI can be done at home and is less expensive, less invasive, and IUI is usually done in a fertility clinic, and it generally has higher success rates. So the process for this is someone will have fertility tests to check that there's no subfertility issues. And the sperm, also the donor sperm, will be checked. So the donor sperm needs to go through a licensed fertility clinic. So it's usually screened for genetic diseases, any infections, and then it's frozen. So the timing for this, so donor insemination is usually done when when the patient's ovulating. So generally they track that by blood tests. And again, as we kind of talked about with the egg collection, stimulation of ovulation can be done, but it's not generally part of NHS treatment. That's usually done, if you need to have that done, it's usually done privately. And then you'll have the actual procedure. So it's basically similar to a speculum. And then in terms of complications, so there's very few complications with this procedure. It's very safe. There's a small risk of infection, but that's the same with everything like this. And then in terms of funding, again, it's not routinely offered, and it varies massively across the country, which is obviously not ideal. It can be offered to same-sex couples after they meet the trying to have a family for 2 years, which is obviously very hard for people to prove or anything like that. They may have to, alternatively, they may have to fund 6 cycles of this by themselves before they're then allowed to have NHS funded cycles. So basically, this is the whole issue around you need to have essentially an additional fertility issue. You need to have a fertility issue before the NHS will fit. So in reality, a lot of people will still end up having to pay. The other option, one of the other options people have is in vitro fertilization, so IVF. So the process is, I'm sure you kind of roughly know. You suppress the cycle, then you stimulate the eggs and collect them, then you monitor the development, and then you give some HCG to mature the eggs, and then when you're collecting them, you're sedated. It's the same as gamete collection. And then the eggs will be fertilized and transferred into the uterus. So if you're using cryopreserved eggs, so for example, if one of the partners is a trans man who's had gamete preservation when they were younger and they now want to use their cryopreserved eggs, then often they'll need to be fertilized with sperm injection because the freezing process makes the eggs harder to fertilize. So there's little things like that which will be different depending on what couple is having the IVF. And then there's a thing called reciprocal IVF. This is a thing in lesbian couples predominantly, where the eggs can be collected from one partner in the relationship and then fertilized with donor sperm and then transferred into the other partner's uterus. That's an option for people as well. Generally, the success rates are higher the younger you are. So actually, the success rates can be a lot higher than average in queer couples because they're usually going through IVF earlier because they haven't had, often cis couples who are having these, cis straight couples who are having these, having IVF have gone through fertility struggles previously. So the timing is often quite different. So then in terms of the complications of IVF, obviously there's the side effects that you need to warn people about. So hot flushes, headaches, restlessness. There is obviously a risk of having twins or triplets. And then obviously the ovarian hyperstimulation syndrome is you've got to warn patients about, again, in this case. And the risk of ectopic pregnancy as well. So when couples go through IVF, everyone is offered counselling before, during, and after, because obviously it's very emotionally draining, physically draining, especially if there's around a cycle where you don't get pregnant. So that's important to make patients aware of, that they can access that. In terms of funding for queer couples, the new Women's Health Strategy for England in 2022 pledged to remove the requirement for same-sex couples to self-fund to prove that they are infertile before accessing IVF, but this hasn't really been implemented yet. So hopefully that will come into practice at some point, but at the moment it's still, you have to have 6 cycles of either IVF itself or donor insemination before you can get NHS funding for having IVF. So again, not great. So another option for couples is surrogacy. So there's quite a long and complicated process. So yeah, I'll kind of take you through it. So first of all, there's lots of surrogacy organizations which can help people who are wanting to do surrogacy. So Surrogacy UK, things like that. They provide resources, and it's highly recommended to use an organization because of the legal complications and everything like that. It can be quite a complicated process. So you would choose whoever you would want as your surrogate, and then you have a surrogacy agreement. So this is between the intended parents and the surrogate. So the intended parents are the couple who have decided to have a child via a surrogate. So that's how they're referred to legally. So you can either have what's called straight surrogacy, ironically. So this would be the surrogate's own egg with one of the intended parents' sperm. Or you can have host surrogacy, which is IVF, and then the surrogate will carry the embryo with either the intended parent's sperm and a donor egg, or whatever combination. So yeah, and you'll have an agreement about how your surrogacy is going to work. So that covers literally everything from the moment of conception to after the birth, and like the legal rights of the child and who's the parent and all of that. And it's very complicated. So in terms of conception, so the age of whatever person who provides the egg is the most important, just to determine whether conception will be successful or not. So obviously the younger you are, again, the more likely it will be successful. Obviously you need to discuss whether you'll attend fertility clinics together, as in the intended parents and the surrogate, or what combination. In terms of the pregnancy and the birth, so it's useful to tell hospital staff what is happening and what the arrangement is, obviously. So, for patients who are coming in for us, so, the advice for patients is to tell kind of whoever's in the hospital what the kind of arrangement is and who is who in this situation. So for us, the important thing is to not assume who's carrying the child, etc. So don't assume anything, always ask what the kind of who is what in this situation. And then obviously important to agree a birth plan jointly between everyone, but obviously the surrogate's wishes will take priority because they're the person who is carrying the child. Then you have to get a parental order. So I'm going to discuss that a bit when I come to the legal issues around surrogacy, but that is essentially determining who is the legal parent of the child. And then in terms of parental leave, both the intended parents have the right to adoption leave and pay, and the surrogate is also entitled to standard kind of parental leave. And then after surrogacy, there's the things like discussing whether the child will have contact with the surrogate, what's going to happen with that. And it's also highly advised to tell children who are born through surrogacy to tell them that from an early age, so there's no confusion later on. And then in terms of the legal issues, so there's a couple of legal issues. So basically surrogacy agreements aren't legally binding under UK law, even if they're signed and witnessed, everything like that. So yes, if the surrogate changes their mind at any point and wants to keep the child, then that is their decision, and that can happen at any point. So yes, you're also not allowed to advertise that you're looking for a surrogate, you're willing to act as a surrogate. So the only way that surrogacy is through these surrogacy organisations who have kind of legal protection to do so. And then in terms of the legal parenthood, as I mentioned, so the surrogate is the automatic parent with, and then the intended parent, so the couple who is having a child through surrogacy must apply to a family court for an order, and that must be done with the surrogate's consent. So this is regardless of the relationship status of the intended parent, so you don't have to be married to have a surrogate, but the child must be genetically related to one of the intended parents. And so it gets quite complicated if one of those is not, if there's any issues around that, because then it goes towards adoption, and it gets a lot more complicated. In terms of payment, so you're not allowed to pay surrogates a salary or anything like that in the UK. You can cover reasonable expenses, so travel to a fertility clinic, for example, but you're not allowed to pay them any more than this. And that can invalidate the legal parenthood if you do so. And then overseas is, again, quite complicated. Basically, if someone is thinking about going through surrogacy, they need to get legal advice, is basically the main advice you want to give patients. But yeah, so if the surrogacy is if the surrogate is overseas, and the child is not a UK or EU national, they will need a visa to enter the UK. It can get very complicated because different countries have different rules on this. So yeah, patients really need to get independent legal advice about this if they're gonna go for surrogacy overseas as well. So yeah, surrogacy is slightly complicated, but the summary is: tell patients to get legal advice if they are considering surrogacy. Yeah. The other option, of course, is adoption. So adoption is a permanent legal process where a child becomes a permanent member of a patient's family with full legal parent rights. So legalities, so it's been a right since 2005 for everyone under 21, regardless of any like marital status, regardless of sex, regardless of orientation, etc. So yeah, it's a universal right, essentially. So you need to prove that you're living together in an enduring relationship. So usually you just need to show that you've been living together for a couple of years. And you can't be undergoing any fertility treatment at the time. And you also can't smoke. So those are important things to tell people. And then in terms of support, again, there's lots of organizations. One for queer families is New Family Social, which is very good. Yeah, there's lots of support out there. Yeah, so that's kind of a brief summary of adoption. Okay, so that's everything. Sorry, it's been a bit of a chaotic summary, but yes, in summary, so we've covered all of this very quickly. So we've covered fertility preservation for trans people and non-binary people. We've covered contraception. We've covered pregnancy, and we've covered some bits around feeding as well. We've covered assisted reproduction, so donor insemination, IVF, surrogacy, and adoption. And obviously this is not an exhaustive list, but this is kind of the main things and what I had time to cover today. So here is a feedback link. while that's up, please do use that to give some feedback. So scan the QR code, give us some feedback. And I'll just leave that up for now. And if there's any questions at all, please do pop them in the chat, or pop them in the Q&A bit. And yes.
Brilliant. Thank you so much, Emily. I'll put the feedback link in the chat. That's not a problem either. There we are. Yeah, so if there are any questions at all, then yeah, pop them in the chat and we'd love to answer them. There was a question I had when you were speaking. I was just wondering, the requirements around surrogacy and things like IVF for same-sex couples or couples with a trans person there, does it look like there's any kind of change going to be happening in those requirements, any kind of loosening of that to make it easier for couples, or do things seem fairly kind of set at the minute?
Yeah, so I think, unfortunately, it seems, well, for the IVF, there is obviously this thing from 2020 that theoretically says that it should be changing, but there's no kind of move, I think, at the moment to change that, which is obviously a shame. But yeah, I couldn't find really anything to say that would be changing soon. Yeah, unfortunately. Yeah.
Okay. Does seem very, very complex and lots of things in place for safety reasons, of course, but very difficult for couples to access, isn't it?
Yeah, exactly. Yeah. Exactly. It is quite complicated. But the surrogacy stuff is less like, you don't have to prove fertility or anything like that. Surrogacy, I think, is generally a bit more queer friendly, I guess, in terms of there's not really any major barriers to having a surrogate, as long as the surrogate has an agreement with you, like, because it's more of an individual agreement between the couple and the surrogate. It's less governed by the government, I guess. So I think it's easier. Yeah.
Okay. So I'll just also put up my Mind the Bleep email. If you've got any questions about anything with this session, I can send on to Emily or other sessions. I already mentioned the session next week on dermatology. If you scroll up in the chat, you can find the registration link for that one. If there's no other questions, then we should go. It is 9 p.m, so definitely time for dinner. Thank you so much for speaking for us, Emily, and thanks everyone else for coming.
Yeah, thanks for coming, everyone. Thank you.
Bye now. Bye.
Bye. Bye.